So, hello, good evening, good morning, or good night. This is Alexander Mameghani. I'm a panelist of the Virtual Global Spine Conference, and I'm very happy to see you all here online. And today's talk is about CSF leaks, which were not intended. So injuries we always have to face in our daily practice. And I can see Dr. Bach is online too. Today is a busy day. Many are still in clinics. The time shift, it's midnight here in Switzerland and 6 o'clock p.m. in New York. I will start and I will make some questions to the audience, and Zoom has a feature, a poll feature, and I will just start the poll, and our amazing fellow Amna I will ask her to ask these questions, and you are able to interact directly via Zoom. There is no other feature. So. Usually I get the call like, hi, it's me, it's Ravi. Can you please come into the OR2? And then maybe it's a screw, difficult screw, or I have to help with a procedure. But very often it's a durateur, and I am the one who is called to fix a problem. And you know, the young surgeons are always very disappointed when they have a durateur by accident. It was not intentioned. It was difficult. Sometimes they are very sad because it was an easy case, a so-called easy case. And I always come in, and when I scrub in and help, I always say, it's me who does the most unintentional durateurs. I have my own theory that it's because I do most of the surgeries in our hospital, and I do the most difficult surgeries. But these are very easy excuses. Of course, you can. You have always to be very aware and to have to prevent any durateur. But literature says 5%. And even in endoscopic spine surgery, the durateurs are more frequent than we want to have this percentage. And I started in endoscopic spine surgery last year, and I had durateur as well in endoscopic spine surgery. So when the attendings, when the residents are very disappointed and sad, you always have to motivate them and see a durateur as a chance. It's not good to ignore a durateur. You can have this situation, even it's late at night, to make your skills better and to improve yourself. This is not a catastrophic situation. It happens to every spine surgeon who is honest and who does surgeries, we have to fix a problem immediately at once. We cannot postpone it like, okay, I close it and I see what happens. We have to fix the dura during the surgery, and it takes time, but please don't ignore it. If you ignore it, the patient probably gets and runs into severe problems. So this is really severe. It's a major complication of the durateur with cranial hypotension and chronic subdural hemorrhage. This is my patient, unfortunately, but this is a session we have to be honest. And what's happening is that your colleagues from neurosurgery make these spur holes and evacuate the hematoma, and they help you. I'm an orthopedic surgeon, and these are surgeries I'm not allowed to do. So then there are other problems, and this, for example, is one problem. Patient obese, of course, but the fusion surgery was really uneventful. It was clear, screws in, laminectomy. It was an easy surgery, but post-operative, the patient had a problem after taking out the lumbar drain. And it was so clear, such a coincidence of onset on pain and removal of the wound drainage, that in my theory, this was the reason that maybe the dura was injured by the drainage when we removed it. This is a theory. I don't know whether anybody ever has seen this kind of complication. We had to revise this patient, and there was a 3 centimeter dura tear, like a cut by a scalpel, like in an intentional opening, but forgetting to suture this this defect, and it is really very painful for us surgeons. You see here a cross connector, and the drainage. I never lay the drainage down on the dura. I always put it in any edge of the wound. But it really, these cases makes me leaving this wound drainage, and I don't like them anymore. But my teacher told me, you have to put in a drainage, otherwise the hematoma will force you to make a revision surgery. You would not have to do if you have put in a drainage. So it's hard, and you see in your own experience you have a shift. It's maybe you have a series of complication by a simple wound drainage. Sometimes you have a complication by leaving them, and then you switch from one philosophy to the other. It's sometimes hard for a team when the leader of the team switches and says, today we don't do a drainage, and the other day we do a drainage. But this is a dura tear with in an amount, in a size, I would not have been able to not see this intraoperatively. But this is not an excuse. It is, of course, surgical complication, and you are responsible. It's not the nurse on the ward who removes the drainage who is the one who makes the problem. So let's start with the easy case. This is a herniated disc. The patient had a pain, classic situation. You decide surgery, microsurgical discectomy was performed, very successful. The patient was happy, went home, and she was really happy until she had a recurrence of the herniated disc, same level, same site. But this time, the herniated disc looks like this. And we all know this revision surgeries are different. What do we tell our patients? Of course, in any primary surgery, I tell them maybe there is an injury, a dura tear, we will have to fix it, and then it's just a longer surgery. For me, I always say it's like 30 minutes, but it can get up to 60 minutes longer surgery than expected. So it's not a 1 hour surgery, it's a 2 hour surgery. And in revision surgery, I tell them the risk of a dura tear is higher. So let's have a look. This is the axial T2, and you see it's really a nasty, big herniated disc, a recurrent herniated disc. You see the primary, sorry, I take this, the incision, it's slightly on the right side. Sometimes surgeons do it the midline straight, in herniated disc, often a little bit lateralized. And you see, I'm a little bit proud of my attending. The joints are completely preserved. There's no resection of the joint. As an orthopedic surgeon, I'm an attorney, I'm a lawyer, I'm a supporter of good joints in microdiscectomy. And you see a nasty big scar. So after revision surgery, this is the situs. You see the herniated disc is resected, but you have here a defect. And you see the nerve root here, some arachnoidea. My question to the audience is very easy. Amna, maybe perhaps you can ask the question now. The question is, when did you learn suturing the dura, and when did you master this technique? Have you been a resident in neurosurgery? Have you been a resident in orthopedics? Did you learn this as an attending, or are you one of the surgeons who always calls your colleague from neurosurgery? Do you rely on their better skills, their longer experience in these dura closures? I think this is really an important point. It's good to ask colleagues when you have a problem and you are really convinced that another colleague can make it better. So when we look to the results, then we see, okay, like the majority learned it in residency, and nearly the 50% or 44 learned it as an attending, so later, not in a residency. This is one of the biggest differences in my opinion, between orthopedic and neurosurgery. You are able to solve these problems earlier in your career. So I learned it in the residency as well, but not in orthopedic residency. I learned it in the neurosurgical part of my residency, and I hope you enjoy this poll. There will be some other polls popping up in this session. So this, for me, is not a difficult situation. Of course, an injury, a dura tear that occurs in this region is easier to solve. Here, there's a risk of making a too tight closure, and the nerve root can be irritated. So this is the video I posted on Twitter as well. You see the CSF is coming up. Interesting, it's always then when the arachnoidea pops up. This surgery was uneventful, but we have seen this dura tear, and then suddenly the water comes up, and we exactly know we should make a suture. So we have heard that many learn it in residency, but the other question was like, what kind of suture do you use? Do you use PDS, Prolene, Ethylone? I asked this on Monday, and interesting, this was the poll with many votes, like 200 decided, and Prolene was the majority. I didn't ask what size, because it would be too many opportunities. And Peter Vicosi, who is a famous head of neurosurgery in Berlin, and who is the president of the German Society of Spine Surgery, he said the blue 6-0 as always. This was interesting because I know he is experienced and he's very wise and a true leader. But on the other side of the Atlantic, Dr. Baj said it's 5-0 Prolene. And when you look to the literature, and I did this before I set up this talk, I searched the literature. What is the common, what is the consensus, which size, which material, and it's our level of evidence is like 5. We only have expert opinions, some case reports, some animal studies, some good experimental studies. They have measured the pressure. Mazda Farshad from Zurich, they set up a really good experimental test center and tried to look what suture is the best for the fascia, subcutis, and skin, not only for the dura. And animal studies, this is without evidence for human medicine, so level 5 expert opinion, which is pretty bad. And this is interesting because every surgeon has to face dural tears. The next was comments from surgeons, mainly neurosurgeons, but also orthopedic surgeons. And it was clear that there is a tie between Gore-Tex 6.0 and Prolene 6.0. And this is very interesting because what do I use? I use Prolene 6.0. But not since a long time. I used Prolene 5.0 before, and I switched to Prolene like 4 years ago, because I was taught on Tycron. And one interesting fact as well, me as the orthopedic surgeon, I take 6.0, and Jonathan Rasuli, from our faculty, he's a neurosurgeon, he takes 4.0. So there's a nice variety, many options. It is a good question from the chat box. Professor Baiza from Jeddah and Kingdom of Saudi Arabia asked whether it's a running suture or interrupted closure is better. This question I try to find, but it is really hard because sometimes only one simple closure, one single knot is necessary when you have got unintentional closure. And I only looked for unintentional dural tears. I think when you do it on purpose for interdural repair, I think all will do running closures.
Dr. Mameghani, do you mind if I add one thing?
Hello. Yeah.
This is a very fascinating poll, and I think it's a long. This is one of those questions that you're never going to get a right answer to. You know, I think the right answer is just whatever suture is best in your hands to fix that dural leak. You know what I mean?
Yeah.
If I may comment, I like 4.0 Neurolon. People say that's kind of old school because that's what we use to generally close to repair or reapproximate dura intracranially for our neurosurgery cases. But for the spine, I personally like it. I just find the needle is good. The handling characteristics are easy to tie. Gore-Tex is fine. I don't like the needle, and I don't like how it can be difficult to throw stitches with it. Some people really like it. The thought is that the filament, the thread of the Gore-Tex is somehow slightly larger than the actual needle itself. So it seals better. I don't know. I mean, does it really make much of a difference? I doubt it. And then Prolene is great. It's just very hard to throw knots with that. I find that it slips a lot. It's hard to throw a tight knot with that. So that's personally why I like Neurolon. But I was wondering, I didn't really see too many people talk about vascular clips. I've used that before in my fellowship too. I forget the name of it. It was called I think it was called Anastaseal. Something like that, like literally just little WEC clips that you would put on the dura, and those work perfectly. I didn't see any issues with those. I didn't see really anyone bring that up, which was interesting.
Jonathan, this is a nice comment on these clips. Do you think that if you always use these clips, you will lose your skill in these tiny, you have a tubular approach, you do a microdiscectomy with a tube, and you have to suture in the depth. Do you think you will lose these skills when you always use these easy clips?
Yeah, so my thought is that yes, to some extent, yes, but those clips are not, they cannot be used in all cases. I think they were only really good for very small durotomies that were relatively easy to fix, maybe with like 1 or 2 sutures, you know, for like a big.
Yeah,
I don't think it's really going to work as well, you know.
Yeah. Yeah, I would love if anybody knows the name of the clips in the US, please write it down in the chat box, because in Switzerland we have got several, not everything is allowed. These are off-label use sometimes in other countries. So
yeah, I'll find out. I'll put it in there.
Okay, thank you, John. So this is a Prolene 60, and these are the microsurgical instruments. And just to make a small joke, this is orthopedic. These are our big instruments, and you see the difference. But as an orthopedic surgeon, I can really use microsurgical instruments as well. So another question, please, Amna, can you ask the audience in the poll, if you use antibiotics, usually we only use single shot pre-operative, but then the situation, you have a durotier, you have to make a suture, and you know you can fix the problem really good. What do you do with the antibiotics? Do you administer additional antibiotics like a prophylactic for several days until the wound is dry, until there is no problem, or do you just stay to your classic algorithm? This would be really interesting for me, because Dr. Bartsch just published a good study last month about the that it's not beneficial to administer additional antibiotics more than this single shot pre-op. And the audience 10 have answered, and the majority says no, there is no need in their opinion to administer more antibiotics. And this is really important, because when you see, why should we do this, then it's really, the literature doesn't support or doesn't give information that if you have a CSF leakage and you fix it, the risk of bacterial meningitis is not really enhanced. This is interesting because we have an amount of durotiers like 5%, but we don't have bacterial meningitis post-op like 1 or 2. It's really seldom. However, if you have a CSF fistula, then the risk is a lot higher. So I hope you can see now the results of the poll, and it's really nice that you can interact on this poll with me. The North American Spine Society, this was just literature from like 9 years ago, 10 years ago, said that prolonged postoperative regimes may be only considered in a complex situation. And if you fix a durotier, that doesn't make a surgery really complex. So I will switch. I am honest in this talk. I use antibiotics until the wound is dry and there's no complication from the wound. But I will switch because the literature doesn't support this regime. So the next case is a woman. And she was in another hospital. She underwent decompression L4-5 for spinal stenosis 8 days before. And the admission to our hospital was on a Sunday evening. The patient was really bad. She had fever. The wound was wet. There was fluid coming out. She had elevated CRP, white blood cells. She had new neck pain, headache, and she was slightly confused. Her risk factors were obesity, diabetes, and hypertension. So this is a classic situation. Weekend, you just prepare to go home to have a Sunday evening with the family, then the emergency room calls you. And this is the emergency MRI. She was confused. You can see it. There were many artifacts. She was not able to lay down calm. She was moving a little bit, but it was really clear that there was a CSF leak, a fistula, and the fluid coming out of the wound was not pure pus. It was too liquid. It was CSF and pus. So if you see these MRI, it is really take your time and make an inspection, because you learn a lot about the previous surgeon, what he did and where the problem was. This here, when you see the red circle here, this was flavum, still flavum there, and the surgeon did the bilateral decompression on both sides. He went here. You see the joint on the left side is completely missing. And it was really hard for me to get information on Sunday evening, because if you call a private hospital, you don't get any information. It's like you're on a call center, and I need the telephone number from the surgeon. I need more information, and they block you and say, no, sorry, we are not allowed to give it was really nasty Sunday evening. So I went into the surgery just with this MRI, and I hoped that I will find a situation that I can solve. This is the post-contrast MRI, and you see nothing else than L4-5 dural tear fistula. So just to make it clear, this surgery on a Sunday evening is something it was really hard for me because it was difficult. Later on, we found this was an E. coli, lots of E. coli. It was really a dirty situs, and you can see here, of course, it was surgery late at night, because if a patient comes in and you have to do this MRI, everything like this, it takes time. But I don't go into surgery without a deeper look into the MRI. So what I found, it was a situation I couldn't manage with a suture alone. Sorry, it was with a suture alone, I had to do a patch. And this is a little bit more difficult than a simple suture, but the infection has eaten up all this tissue. And after I have decompressed properly to see the surrounding borders of the dura, the stitches were just cutting through the dura, and it was not possible to close it by a suture, not a running suture. I had to take a patch. I would love to hear from you in the chat box, what kind of patch would you use in an infectious situation? Would you take Gore-Tex, which is a foreign body, or would you take muscle or fascia? I would love to hear your opinions. Because I've taken a fascia, and I did many sutures to fix this hole, this big defect with the patch, and it worked. It's really a good result. And this is the MRI. 3 months later, you see there was no CSF leak anymore. The patient was fine. The infection was cured by antibiotics. There was no foreign body, no screws, no implants, and the patient was very unhappy because of the situation. Totally, she was thankful, but she was unhappy, still pain. And if you see here on this MRI, like 1 year later, you can see that the rootlets inside of the dura, they maybe are a little bit sticky. It's arachnoiditis after infection, after meningitis, and it is really clear that I cannot help the patient as a surgeon by direct treating L4-5. Maybe she will benefit from a neurostimulator later, but I think this the situation with the patch is solved, and these skills, how to insert and how to suture a patch to the dura, is an important skill. I'm happy that my teachers have taught me this. The patient is clearly convinced she will never undergo any spinal surgery. This was a nightmare for her. This is from the OR report, just for highlighting the problem. Of course, there was infection, but the problem was the fascia. There were 2 single stitches close the fascia, and there was no suture performed, although the dural leak was noticed and described. The only patch was Tachosil. I hope you all know Tachosil. I don't know it's like a fibrine layer, and this was really difficult for me. It was complicated, but I found out that if you only do a Tachosil patch on the dura, you should not leave the fascia just with 5 single stitches. So on Twitter, Dr. Horta from Cuba mentioned that he has good experience with adipose tissue. And please write down in the chat box whether you do use adipose tissue as well. You have to see that not all surgeons are able to use these amount of industry given patches and glues, but adipose tissue, you can use it in the night, you can use it anytime. You don't need a company, you don't need a sales rep, and you can use it. I just have read in the chat box there was a question whether I placed the lumbar drain from Dr. Birchuk. I did not, and I don't use lumbar drains in infectious situs, but I will mention this topic later. So the next case is a lot older. He's 80 years old, and he was hospitalized in another hospital because of pneumonia. It was end of the year, it was December, it's what, influenza B, and then he had a bacterial superinfection. And interesting, 2 years ago, he underwent decompression L4S1, but it was uneventful for 2 years. And then there was a new low back pain. He had persistent bacteremia, although the bug was known and the antibiotics should have solved the problem. But it is interesting, the delay, because this was the lung, the chest. He was in a bad condition. This was the MRI, and I didn't blind the date because it was December 27th. It was 1 day after Christmas, and this was known. And I think it's clear for us now in the retrospect that there is a spinal infection. This is contrast enhancement, and there are some small abscesses in the rector, but the colleagues continued giving antibiotics. And 1 week later, the patient was really bad, bacteremia still ongoing. And then they sent the patient to us, and you see there's a vertebral osteomyelitis going on, epidural abscess. And the patient was in a bad condition. And so we decided to take him to the OR and debride the joints and the muscle. And I started the surgery like, okay, this will be like 30 minutes, maybe 45 minutes. It's not a difficult surgery. Whenever I see a patient post-op 2 years later, I expect a solid scar, a thick tissue layer on the dura. And then I was really surprised. There was no scar at all. And suddenly there were structures running from cranial to caudal. And I was just seeing inside of a non-existent dura. I've seen inside the thecal sac, and everything was destructed by infection. And so this is like 2 weeks of bacterial spinal infection without adequate treatment, without debridement, and the dura was gone. And so I was in the OR. There was a sick patient, a huge defect. I was not able to make any suture. There was only, like in an anatomy situs, there was the fascicles. This is the situation I just have to describe, and this was so long ago, I didn't have the opportunity to make a video. I would love to hear from you in the chat box. In this situation, crying is not an option. What do you do? And I can tell you what I did. I said, I don't want to play a long-lasting game. I don't want to lose time with a really sick 80 years old patient. So I did some layers of tachosia. And then I did the best suture of a fascia I've ever performed. Not only several stitches, I take this PDS loop. You can take any material as you want, but I take PDS because it's resorbable, it's long lasting, and it's got good biomechanical properties. And I take this loop and I perform additional layers to make the fascia waterproof. This is when the dural tear is persisting. I think this is from the case before, something I really learned in my life, not only from the textbooks. I learned it in the OR, that the fascia, if you close it properly, is really helpful. So this is the MRI 1 week later. This is 11th of January, the same patient. You can see the layers of tachosia. It's important not to compress. It should not be a tumor lying on the in the spinal canal, and the fascia is closed. I asked on Twitter on Monday whether oversewing of the tissue layers is something you do regularly in these cases, or do you think one good layer is enough? And it's interesting, I'm the one who is always oversewing. I did experience that it only takes some time, but this time is really good for the patient's safety. Now to the question, lumbar drain, yes or no? Amna, can you please ask the audience, when did you last time use a lumbar drain to decrease the pressure on the durathac in case of unintentional dural tear? So not intentional, unintentional. I can just give you information. I used this lumbar drain the last time in 2015. Knock on wood, it's like 8 years ago. I managed always to solve these terrific amount of dural tears. You know, 5%, it's my percentage as well. And if you do hundreds and hundreds every year, this is uncountable sutures I've done. And again, knock on wood, it was a long time ago. And when I see the results, and then I can see that there's really, some are using it recently or some time ago, but some never did a lumbar drain or a long time ago. So I hope you can all see the results now. And I don't do this. But 3 weeks later, the patient was doing better, and I thought, what is happening to this? I don't want to, because tachosia will resorb. I'm curious, what will these nerve rootlets do in the future? So I asked my boss what shall we do? And he said, wait and watch, because the patient is doing much better. And so this was in my career when I was in the university, and we had a lot of money. I examined him now for a long time. So this was 3 weeks later. You see this tennis ball is still there. It's round. The fascia is really tight. And for my experience is the most important region where the fascia closure is really important is the cranial part. Most of my patients from other hospitals I've seen, the CSF leak goes this way and maybe then around, and it's not the caudal part. But this is my personal experience. Please write down in the chat box whether this is nonsense or only one surgeon who sees this. So I always tell my attendings and residents to close the fascia properly in the cranial part, second, third layer. So this was 9 weeks later. We are now in March 2014. The thing is, there's a membrane. It's not complete. You will see on the axial T2, there's a membrane inside of the thecal sac. You see a lot of contrast still ongoing, but the infection was healed. The patient was ambulatory, was in home. And this was 12 weeks later. There was a shrinking of the CSF collection here. The fascia is closed. And this is in December. This is 1 year post-op, nearly 1 year post-op, post-infection. You see there's a layer here, back again. Like a pseudo dura or a dura, I don't know. I will never see this situs again because the patient is doing well. And this is only possible if you do a good closure here, if you can't fix the problem here. The next patient is one of the complications in these big surgeries. She was operated in a private hospital in a big surgery, T10 pelvis with XLIFs, and intra-op there was a durotear, but the surgeon fixed it. And then the patient was sent to rehab, and from rehab to our hospital. This is due to our availability 24/7. We are here, the backup. And so when the patient was in a bad situation, she was not complaining so much from back pain, but her blood culture was positive for coagulation negative copy. So this was the X-ray. She came to us, and this was the MRI. It is so annoying not to get beautiful images, but this is real life. I called the radiologist and said, sorry, but I have to send the patient back again to your MRI because the quality, I cannot use it. And then we have a discussion why the images are bad, the implants and slight movements, and we have to put her under anesthesia, in general anesthesia for the MRI, and it's really hard. But this was the best MRI I could get. And what are we dealing with? We have a long construct. We have a history of durotear. We have this Staphylococcus epidermidis. We have an implant-associated surgical site infection, and no better MRI is possible. This is an axial T2. I cannot tell you where is the CSF leak. I have to rely on the surgeon, of the primary surgeon, who said L5 is 1. So what did I do? I took her to the OR and I opened the complete scar, the complete wound. Why did I do this? Because it's a surgical site infection. It's an implant associated. I have to do debridements, taking biopsies from everywhere, rinsing the wound, debridement of the soft tissue. And I didn't find one durotear. I found 2 durotears. Interesting, the other durotear was L2-3. There was CSF coming out from L2-3. She had previous surgery here, but in the last surgery, it was an XLIF level of XLIF. And Post-op, when the patient was calm, we could do MRIs and we could see the problem was solved. These are these nasty CSF leaks leading to disaster after these long constructs, and it was weeks later. These low-grade implant-associated infections are really painful for us surgeons. Sorry, I have to use this here. Sorry, I'm here. Yeah, now. So this was the X-ray standing from the beginning, and then unfortunately she went into proximal kyphosis, junctional kyphosis, and my question to the chat box is, what to do now if you know that she had a dural tear, she had an infectious, and I just wanted to tell you what I do in this situation is not opening the whole wound, just connecting and going cranially. I know exactly that the sector balance could be achieved better via an osteotomy in the L4, L5, but I was not eager to do this. So I did this, a connector. She was straighter, but it was not the end of the road. So there was pseudoarthrosis, a problem was ongoing, and the junctional region, I had to do corpectomy, and finally I did the job deep down, L4 osteotomy, and to prove, to make the sagittal balance better. And between the infection and the last surgery has been 2 years. So the next surgery is something for Mike Salby in Australia. She had 6 surgeries within 9 months. The first was just a Wilsey approach, extraforamen discectomy L4-5 right. But the patient wasn't happy. Shortly later, she had leg pain again, and then we did an interlaminar microdiscectomy, and in this surgery there was a dural tear. The third surgery, shortly later, because the pain persisted and we thought it was the instability, L4-5, we did a TLIF, and again a dural repair. 3 weeks later, debridement because she had a surgical site infection again, the same bug, low-grade Staphylococcus epidermidis coagulase negative. Then she, because the cage was undersized, I showed the images because this is the case for Mike Salby, and it's a bad TLIF. I did an anterior debridement, removed the cage, and did an ALIF. And the last surgery was the posterior exchange of the loose implants and bigger screws. So this was the bad TLIF, not enough lordosis and infectious, and later there was a loosening. So this was the MRI, and you see there was no CSF leak any longer. And this was the ALIF and posterior revision. And I thought I did a good job. And she received antibiotics. And I thought I was on the winning road. But then she complained about belly pain and a swelling. Then I thought, okay, I sent her to gastroenterology, and they did a CAT scan, and they found this collection. On the left side, it was retroperitoneal. It is a big tumor-like lesion sitting on the left psoas muscle, and we did a puncture, a biopsy, and it was CSF. So we have had a CSF collection retroperitoneal on the left side, which was symptomatic because she had pain from the genitofemoral nerve. There was like an impingement. This was the first I've ever had, but here she had a problem. So this was the myelogram. I thought I can see anywhere where the dural tear is, because Mike Selby says CSF leak in ALIF is really rare. It is rare, but it happens. But I couldn't localize anywhere the CSF leak. And you see, while the bone effusion is ongoing, the CSF leakage persisted. We punctured like 500 milliliters. She has never had any headache. And then 1 week later, this collection was back again. We could see it with ultrasound very nicely. This is the MRI, and when you do several examinations, we did CAT scan, myelogram, MRI, then this T2 was the one that helped me mostly, because I could see like a funnel between the psoas muscle and the lumbar spine, L4-5, and I thought, there is the problem. Here is the problem, and I have to solve this problem. Or do you have other comments? Options. Maybe you know, we always have our shunt patients, and the shunt is intraperitoneal, where the CSF is absorbed. And so I just wanted to ask you whether any neurosurgeon would be brave enough to put a shunt from the retroperitoneal into the intraperitoneal, because I discussed this and they said, you know, infection, shunt, this is not a good idea. And maybe a blood patch, but where to put a blood patch here? The CSF will have a small, like a small river running next to the spine or to the cage, maybe on the right, maybe on the left side. I cannot visualize this. Suturing, can we suture anything? Can we explore from posterior, or is the smartest solution, wait, it will heal? The patient was not willing to wait. She wanted to have a solution. So what did I do? I took her back into the OR and I did an anterior revision because the access is really easy. It is just like you go you're going just like here, your former approach, and then this space is like nothing. You are here within 1 millisecond. And what did I do? I put in TCL, like fibrin glue, into this funnel, and I sutured it with PDS. And I was lucky because she had no reoccurrence of the fistula and of the collection. You can see here on the right side the MRI. It's the newest. And the patient was happy, no swelling, no belly pain. So this was the last case, and I just wanted to ask you a honest question. And Amna, this is the last question I would love to ask the audience. What is happening with your own personal percentage of your tears in your career? Are you getting better and better, and your percentage is decreasing? Like, okay, it was 5% 10 years ago, and now I'm like 1%, or ideal is 0, or are you pretty facing a constant percentage of your tears? Or do you do more and more difficult cases? Do you do more and more revision surgeries, and you have to face more and more often your tears? And so while you're able to use this polling tool, I would just say my percentage is pretty constant. I'm not getting better. I don't have times like, oh, I have 6 months no dural tear. It is really constant, this percentage. What is getting better is these percentage in primary easy cases, but the amount of difficult cases is really overwhelming. And so my percentage is still the same. Mike writes down the chat box that since he rarely do decompressions alone, that his percentage is getting down. And Professor Baeza says or asks whether Duracell. I don't use Duracell. There are, maybe I'm a little bit biased by my teachers. I have this Tacozil, which is a fibrin layer, and arachnoiditis I don't see very often. I see arachnoiditis in infections, in low-grade infections, and then I'm really, without any weapon, I cannot make this better. In my practice, I introduced Hamopatch new and replace a little bit this Tacozil, but I think every surgeon, like Jonathan Rasuli has mentioned, needs to have his own tools, his own weapons in his armor, I cannot give you an advice what kind of suture or a patch or which company you should use. But it is important that you stick to this topic. It's badly represented in the literature, but it's our daily problem. When the Dr. Wheeler asked in the chat box, what do I do when the patient has still headache and a leaking wound post-operative day 1? So post-operative day 1 is not a good day to make big decisions. The headache, the leakage, and the loss of CSF can be heavily in the first 1-2 days. But the last patient I did with the revision, she was fine after 3 days, after 4 days. So I'm a little bit patient, but I keep them in my hospital. I'm not forced to send them home as soon as possible. The hospital admin is not calling me and ask, hey, why is the patient still there? I'm in the lucky situation that the patient can stay in my hospitals. I would like to thank you all for participating and that you all answered the polls, and thank you very much for your loyal appearance here on this conference. I appreciate really that you logged in and to hear an orthopedic surgeon talk about CSF problems. I'm convinced that neurosurgeons are the better and the more skilled and the better skilled dural experts. But we don't have a neurosurgical department here in my hospital. It's pretty easy. We have to have these skills. I cannot let any patient operated in my hospital, and when you do a tear as big as it is happens, and I say, so that's it's a fate. Because it is gold standard today that we fix the dura as good as it gets, as it has to be our primary aim to make a waterproof suture. Then the second is the fascia and the subcutis, and we have to be really looking for the patient. Bacterial meningitis is something we don't want to see this. The patient is always unhappy. So next week, I have heard that Dr. Molina will present cases, and I'm really happy to see you all next week again here on the Virtual Global Spine Conference. So goodbye, everybody. Have a good night or a good day.